welcome Paul to this session, and welcome all the participants. I'm really looking forward to hearing more from Paul about his company's approach to health and care and digital solutions. So welcome, Paul, and over to you. Take it away.
Hey, David, thanks very much. Yes, I'm Paul Rylance. I'm CTO at JKM Care. Our founder, Josephina, is a doctor in clinical psychology. She spent 20 plus years at the front line of health and social care, with a very keen focus on patient flow and discharge. Myself, I've spent 27 years in very, very large scale IT. Most of it in the global arena, most of it in web-based. I'm a former HP consultant, and I've delivered global scale solutions to some pretty well-known brands. But it's not about me, it's about health and how we can help. So this first screen is only here to initiate those people who are not aware of the current scenario. But everything is very much silo-based. And as you can see here in blue are the segments that I think that the federated data platform will be covering, and hence it's only doing about 40% of the overall scope of health and care from a potential patient perspective. So I think one of the challenges is to how we actually start joining these things up as and when necessary from a patient or carer perspective. So I've highlighted the acute there, so we're going to drill in. So we've got these high-level silos. Let's just go and focus now on the acute setting. Next slide, please, Jay. And the acute setting is pretty much controlled by an electronic patient record system and a patient admin system. And these systems are historically end-to-end, the UI, the business logic, and all the data is encapsulated within a software package. Whilst this is great and convenient, it's really, really inflexible. And I think a better way, a more flexible approach for everybody concerned, is to start stripping these layers out. We've had recent conversations with people about the UI, very mixed bag of comments and returns. But the thing is, flexibility is now, or should now be, the focus. And having everything tied together is quite inflexible. Next slide, please. So what's the answer? What's the solution rather than the silo-centric approach? And we'll call it a silo-agnostic approach, and we'll also say that it's not a system, these are more repositories. So we all appreciate that the data has to sit somewhere, but it doesn't have to sit within a software package. It can merely sit in a repository. So if we hold that into our minds for a moment, and I'll go through some of these, but definitely not all of them. So why should we go for a repository? Well, if we look on the left-hand side there and we see clinical, that clinical repository will hold all the information about patients, the interactions, interventions and episodes, whatever language you want to call it. They will all be contained within that repository. External monitoring could have a repository itself. Pharmacy would have a repository. And you say, well, why would we need all these separate repositories? Why can't we just nail it all together and hope for the best? And it gets down to flexibility again. So if we wanted to look at pharmacy specific, we wouldn't have to go wading through reams and reams of patient data, arguably sometimes very sensitive data. We could literally just look at the pharmacy repository and get volumes, dosages, all manner of information and outstanding prescriptions and whether those prescriptions are actually consumed, etc., etc. Now we've got Spine here, and Spine already sort of demonstrates this repository type mentality. So Spine is a centrally held system. It's pretty fast. It doesn't rely upon the standard database type scenario. It runs in memory, and it bats, I think, at least sort of 10 million requests a day. Happy to stand corrected on that. And so anybody that wants to know about a patient, where the patient might live, their address, the various demographic details, then they can go to Spine. They can also go locally to an EPR, but again, that is bound data. You can only get it from a local EPR. So Spine sort of adopts this sort of silo agnostic approach because it's available globally, and it's available to social care as well, if and when needed. And now NHS England and NHS Digital have stepped up and said, well, we want this to be the de facto starting point for all patient demographics. So as I said, I won't go through all of these, but we have A&E arrivals, and this is more an operational thing, because whilst we can have all the clinical focus and all the clinical energy that happens within A&E, that will go into the clinical repository. But if we wanted to look at more operational things, then we should be looking at, well, when did a patient arrive? Not who saw them and what happened, what interventions. That will stay in the clinical side. And so by virtue of the fact that we start having these individual repositories, we can almost think of them as playing cards. And if we paint a scenario, we can choose which repositories we would actually need to look at. So if we wanted to, let's say, look at purely discharges, we'd be looking at bookings, the bed bookings, the actual delays to see if anybody's already delayed, and transport and pharmacy, because those are the four big areas where delays are often incurred. And you say, well, hold on, it might be capacity outside of the hospital, and you'd be absolutely right. And that's why the repository for bookings would cover everything from respite to care homes, to residential homes, to community hospitals. Anywhere where a patient will potentially lay in a bed will be controlled by the bookings repository. So if we wanted to see the journey that a patient took, which beds, which wards they were in, we'd be able to do that without, again, having to trawl through the very sensitive clinical data that are currently held in these silo-centric systems. So then that opens up a whole gamut of possibilities for research. We've got staff rotas there as well, and that doesn't have to be limited to the NHS. It could be expanded. And there may be scenarios where one of these repositories doesn't actually fit a future need. We've got several examples within JKM where we know the data currently doesn't exist, and we've created technology that will allow that data to be captured, and we're doing it in this silo agnostic approach as well. Next slide, please, Joe. So let's just understand what the repository is. It's probably a data store, and the clinical repository, because everybody's familiar with this, everybody likes to talk about patient record and so forth. So the clinical repository, as I said, will hold all interventions, whether it's general practice or community hospitals or acutes, and yes, even dental. All of those interactions will go into the clinical repository. This is very similar in some ways to the approach they've already taken with One London, where they're aggregating all the data from existing EPRs, cleaning it and making it into a common lookup language. And then everybody can sort of take that data and start mapping out their needs. But again, it still relies upon the electronic patient record at the silo level. So what we're suggesting is perhaps a more flexible way is not to have it bound in the silo, but have a greater general repository. But that's all it is, it's a repository. And I would strongly recommend anybody who's got an interest in looking at the more clinical aspects of care to go and look up Dr. Mark Wardle, who's over in Wales. I believe he's a neurologist and a CCIO over in Wales. He's been doing some excellent work, and I've left a couple of links as references there. Please go and look up his work, because it very much aligns also with the mentality and the conceptual approach that we're describing here. Next slide, please. So if we've got this repository, this clinical repository, it's going to be stratified. There are going to be layers about it, and arguably the top layer is the most recent thing. So you could almost align it with the summary care record. What meds am I on right now? What treatment have I just received, etc., etc. And the deeper you go down into a clinical repository, the older the information, but arguably just as detailed. And so that repository can't just live on its own and work on its own. So we need an interface. We need to be able to look at that data, but look at it in a way that suits us. Again, this is another restriction of the silo-centric sort of electronic patient record approach. So it's a sort of one size fits all. So if we had a viewable scenario, and one doctor said, well, I don't like this amount of information, I don't need it, it's not relevant to me, I want to be able to configure my user interface to suit me. Yeah. Now that can also apply for social workers, that can also apply for patients, and it can also apply for carers. So in this scenario, if a patient said, well, I want to look at my data and I'm not interested in all the potentially detailed clinical information, but I just want the high level, then that would be really, really easy to do. Yeah, and there would be very little business logic in it. Similarly for research, if people wanted to do that deep dive into this huge data lake, they could do, and it would be controlled, and they too would also may have the need for their own interface. This is how we want to present or look at our information. And I've also included ambulance there as well, because they have a foot both in the transport side and in the clinical treatment side. So they may want to say, well, my interface, I want to be able to see some of the clinical detail, but I also want to be able to see some of the transport detail so that I can be or operating at the most efficient along with my control team. Next slide, please. So once we start stepping outside of that purely clinical space, and I appreciate that a lot of people do focus on the clinical data, but if we take the analogy that I've just explained and then start expanding it to potentially all of the other scenarios that a patient may incur along their journey, and which could include adult social care, it could include care homes, it could include bookings, that's inpatient bookings, appointments, and appointments will also include daycare, or it could also include electives, and by virtue of the fact that it might, we will have a loosely coupled relationship between appointments and bookings. And so once we start looking at it almost like a drilled ice core, if you will, from the Antarctic, not only can we see exactly what happened along the patient journey as a whole, and we can zoom into any particular facet we like, we must also appreciate that the organization and the coordination of these things is usually not linear. So we would like, before a patient finishes their clinical interventions, we'd like to organize the pharmacy, we'd like to organize the patient transport, we'd like to organize the communications that may go out to families or carers or to the patient themselves. And all those things need to happen, and the result of them happening may be linear, but the organization and coordination of them is far, far from it. And you'll look at the bottom there, and we've also got delays. And you say, well, I'm a doctor, I'm not interested in delays, and that's fine. You know, there are lots and lots of people that are deeply focused into delays, And that may be their world. And they say, well, I want a user interface that focuses not just on the delays from a hospital perspective, but the delays from a patient journey perspective. Why were they delayed? How long were they delayed? Was this the only delay reason, or were there multiple delay reasons? And it gets very, very complex very quickly, but with the right user interface and the right people inputting into that, it can be made very smooth and removing the visual complexity from it all. Next slide, please, Jay. So what are the benefits? And I'm barely scratching the surface here. So if we imagine that we have clinicians that have said, this is the way we want our look and feel, and we save that in a configuration file, and a doctor then moves, let's say, from King's College Hospital in London up to Manchester, he can actually take his configuration with him. So there'll be zero learning there. There'll be no, oh, well, we use this type of EPR and this is how it works and this is how it flows. You'd just be able to say, well, I've already got my configuration and I will just draw the data and I will view it as I need to view it. So the training side is almost removed. So you can actually have a clinician, for want of a better expression, hitting the ground running. So I won't go through each and every one of these items on the list, but some of the change control. So in the scenario where, let's say, a clinician says, hey, I can't access this. I think it would be good information. Can I have this change? And that change would literally take days or weeks. And then somebody else says, oh, I want that change as well. And therefore, because we're doing this repository type approach, that change is instantly available to every clinician up and down the country without having to reinvent the wheel, without having to pay other people, without having to wait for a different way of doing things. And if a trust says, well, we do things differently, well, all it's down to is a configuration file rather than, as I say, reinventing the wheel. If we look at it from analytics and this repository mentality, if somebody wanted to analyze, let's say, transport, to look at the carbon footprint, they could look at it nationally, and they could drill down all the way down to an individual journey if they desired, without having to seek individual permissions from individual trusts. The data would just be there. So it would be one authorization and the agreement of how deep you're going to scoop, how far you're going to scoop, whether it's actually patient transport or whether it's patient and equipment and documents, or every type of transport would be modeled and fashioned and stored in the repository. So I think I've rattled on enough. I'm hoping my time is pretty good there, Jade. And I'll happily open it to the floor. If you can open the next slide, please. Oh. So yeah, the good news, this all may sound quite conceptual and quite freaky. The good news is that in JKM Care, we have done a lot of the heavy lifting. We have worked on this for 7 years. We've done deep dives in every facet that we can, bar the clinical information, because I think there's a lot of players in that space and a lot of people have interests in how that needs to go. But that doesn't detract away from the repository approach. And therefore, the work we've been doing enhances this repository mindset. We've done the more operational things of the transport, the delays, the A&E arrivals, the patient flow as a whole. And if anybody wants to have a discussion with us, even a demonstration of how that works, how it might look and feel, we'll be happy to hold those discussions. Next slide, please, Jay. And so if you want to get in contact with us, there are our contact details at the bottom there. We're always monitoring our emails. We're always monitoring Twitter, or dare I say X. So yeah, please drop us a line and we'll be happy to chat to you. And I think now is probably a good time to open the floor up for questions.
Paul, if I could start, if I could just thank you very much for a fascinating presentation. For me, it's really good because, as you know, one of the key themes that I'm trying to foster is around using digital to integrate across health and care, which I see is very much part of your focus, and I think that's just fantastic. I really feel it's an important principle that we should try to keep exploring, in this forum. So yes, are there any questions that anyone has? I mean, I know I've got a number, but before I come in, who would like to start off with a question? I'm not sure how to.
May I say, I can't find the button for putting your hand up. Sorry.
Raising the hand, yeah.
Visible hand's fine.
Oh, okay. I see Brian has raised his hand, but why don't we go with Brian? The thing is, he may not be first in case there are others who have tried, but anyway, it's good. Brian, please, what's your question?
Thank you very much. Very interesting. And I know that the NHS is very keen to break the monopoly or the duopoly really of EMIS and TPP. So this is an interesting way of doing that. I'm a retired GP, and the way the GP record is now, electronic record is now set up, is actually very convenient. So I can easily look at what's happened to the patient. I can look at their pharmacy. I can actually look at the hospital record as well. So if it was in a repository system, as you describe, how easy would it be to look across? I mean, I might want to see half of those items, those repositories that you mentioned, at the same time. I might want to be zipping across some of these, the pharmacy, the discharge, and it would be wonderful to have access to social care and community nursing data as well. So how flexible would that be? And then the other sort of related question is, it's been an ambition for patients to have access to their NHS social care, dental DWP data. I've been kind of keen for that for 20 years. And is that on the horizon at all? So thank you very much.
Very, very good questions, Brian. Thank you very much. So flexibility, yes, is the answer. It would be very flexible. And rather, again, without sort of breaking the record, without having to go to each individual trust and trying to access an EPR and pulling the data back, you just go to one place. You say, I'm looking for this patient. This is how much I want to look at this patient. This is how deep I want to go. This is how far back I want to go. And this has been demonstrated really, really well in the commercial world. If you think when you go on holiday and you want to book a flight and you may want to book a hotel and book a car, it's all there on one screen for you. That is, in essence, multiple systems being accessed in real time. And so you say, well, now I've picked my flight, then that information is being taken, and you will then want to book your hotel, and it will already use the dates that you've provided from your flight. And then it will ask you, oh, do you want to do a rent-a-car? Oh, yeah, that would be great. And all of those dates are already moved across. So, it's fairly common in the commercial world outside of health. So it should be really, really easy to access these individual repositories. Obviously, the access and the control will be down to the person who resides over them. Your second question about patient access, there's absolutely no reason why an interface could not be created, co-designed, and that even when it's been co-designed doesn't mean that it's fixed either. So if it's launched and people say, oh, I can now just go on the web and I can look at my record, can I actually take it with me because I'm going on that holiday I've just booked with that rental car and that hotel? Can I take it with me just in case I've got a problem because I've got long-term complex needs? And in theory, and I guess in practice, I guess it's all down to politics and who owns the data and who can have the data. But technically, it's really possible. You could literally take it with you. Does that answer your questions, Brian?
Yes, thank you very much. That's very helpful. I mean, in fact, you can access your records now and you can just access it from anywhere. So that's possible now, but it's only for NHS or GP record. So we would want to expand that if we could.
I think one of the limitations, if I'm not mistaken, is if somebody's abroad and let's say there isn't internet access there, then suddenly there's no access. So there should be no reason why somebody can say, well, can I download it? Can I have a wearable? And that wearable could be a brooch, it could be fixed on your watch, it could be anything. And you could actually download it. And then everybody who went to that repository would also know that you've downloaded the latest copy or when you download it. And that starts to give some really exciting opportunities.
Thank you. Helen, you have the next question, I think.
Thank you very much for that, Paul. I guess my question is, this is what you've presented is really interesting, but I see it as largely theoretical. Do you have demonstrator sites where you're building this capability in real time?
Okay, well, we've actually, Vidimo as a platform, this is a software we've created. We could demo that to you at any point in time. The only bit we don't cover right now is the clinical, and that's because we would need to integrate with the existing EPR systems. But from a concept, in our demo, we've got 43,000 beds loaded across all care settings. That's community, acute, care homes, respite, extra sheltered, etc. Sorry?
So I was going to say, are you interested in doing research to do more about this linkage?
Yeah, absolutely. Yeah. We did speak very briefly with one of the institutes in London, the Turing Institute. So yeah, would be very interested with any research in this area.
I will contact you offline because I represent the National Institute for Health and Care Research, and this is an area we've now got a research program on social care, and we may be looking to do something around tech-enabled care. So this might be a bit beyond that, but I also have another link that I might make for you. So I will contact you directly offline. Okay,
yeah, that's brilliant. I'll just I'll expand on your thoughts of social care. So the scenario we often paint is, let's say there is a patient who's at home and that patient has some domiciliary care, they may have some community nursing care, and they get visited 4 or 5 times a day. If that person's taken ill in the night and they end up going to A&E, and then the A&E person says, well, you're quite old, elderly, Doris, let's put you into AMU for a couple of days. There's no notification, nothing happens outside of that. So the next morning, you have both domiciliary care and nursing pitch up at Doris's home. There's no access. They fear the worst. They call the police. 2 big burly coppers pitch up, ram down Doris's door, and then all 4 of them stand in Doris's living room saying, oh, she's not here. And then when she's ready to be discharged, she can't be discharged because she hasn't got a front door anymore. Yeah, and this is such a common scenario. And so while she's waiting for the front door to be replaced, she deconditions, and therefore she has to go through the cycle again. So all it would require, and this is what we've solved with Vidimo, is if we knew Doris had got these care packages and visits in place, all we would need to do is send a message in real time to say, don't go to Doris's. You don't need to know why, but just don't go to Doris's. We'll tell you when to start going to Doris's again. And we've spoken to domiciliary care and nursing people, and they said, God, this would save us hours and hours of frustration. So yeah, it would be great to chat to you, Helen.
Thank you very much. Eddie, what's your question?
Yeah, thanks, David. Thanks, Paul. Sorry, I came late to this meeting, so I'm trying to pick up something, not say something that was completely obvious that you said earlier. I'm Chief Exec at Oxfordshire Association of Care Providers. So we work with social care across the county of Oxfordshire. I'm also co-chair of the Care Association Alliance across England. Mm-hmm. I'm really interested by this. We a lot of our colleagues and ourselves run a digital social care support service across our patches, supporting care providers to make sure they've got the necessary protections in place to enable them to access NHS services like proxy access, etc., and in care homes EPR. I think my concern, and I think it's a great idea, by the way, Paul. I think we're really slow within adult social care about rolling out this kind of stuff. Mm-hmm. Just the other day, I was chatting to our ambulance service around potentially enabling home care organisations to have access to the NHS 111 directory of services, mm-hmm. so that they don't have to go through the 111 service. They can actually triage itself themselves, mm-hmm. in terms of what they need. But this stuff is so slow to get off the ground. We don't have the data agreements in place. We don't have the leadership locally. We don't have the funding actually to push it forward. Mm-hmm. And the other issue we have is, of course, a lot of social care providers have their own systems which they've done on commercial reasons, so care planning systems, etc. Mm-hmm. And my feeling is that the system tends to work with bed-based services first. So it tends to work with nursing homes, care homes. Mm-hmm. It's only just realised during the latter part of COVID that actually domiciliary care exists. And there's actually, that's where the major part of social care is delivered, is in people's homes. Yeah. So we've got a long way to go. I'm aware there's pilot projects across the country, but they are so low tech. It's unbelievable. So things like asking older people to wear a wristband, so when they go into hospital, the acute hospital can then identify that they might have a care package at home, etc. I mean, that's how unjoined up our system is. Mm-hmm. GPs don't necessarily know that person is has a care package because they might be self-funding rather, mm-hmm. than local authority funded. Mm-hmm. So we just have such a long way to go in terms of joining this all together. And I just wondered, I'd be also, by the way, willing to talk to you, and also maybe inviting you to a care CAA meeting to talk about, mm-hmm. how we might move forward and how we can work with digital social care to move forward. But, a lot of this is outside of our control. It's kind of in the hands of very senior people, DHSC, etc. But I wondered what kind of steps could we take to begin to join all this together, because it is a massively fragmented jigsaw puzzle that we're looking at, but has enormous benefits in terms of that EPR access, enabling both, as I think Brian said, enabling the GP and the care home to look at effectively the same information, so you can see that in real time.
Yeah, well, there's two very easy answers to the question you just asked. Firstly, don't go for what is perceived to be the path of least resistance, and that means, let's join up the existing systems, because it sounds the go-to approach, and usually, from my experience, it's completely the opposite. So understand what you're trying to achieve, and then establish whether you could actually achieve it with either incumbent suppliers or the approach that you've currently got. That's probably the best answer. Sometimes it may be greenfield. It might be easier and it might be quicker to go greenfield. It depends on the level you want to go down to and the breadth of how far you want to reach. I'll just expand slightly on my Doris scenario, and this is also a familiar world for social care, of house cleans, blitz cleans, and how they actually impact delayed transfers of care. So clinically, a patient may be ready to rock and roll out of that hospital, and then somebody at the 11th hour said, oh, we didn't order a blitz clean. Oh, there's a blitz clean scheduled for Wednesday and it's now only Monday, and therefore the patient is now delayed 4 days, and it's on nobody's radar. And these are the operational things that we're really trying to nut out to give everybody absolute clarity. I hope that sort of fits in with your mindset.
I'll just fill in a little bit further there. So I'll give you another scenario, which is live. So we run a trust assessor service out of our local acute hospital, which effectively is the care provider voice in the hospital, ensuring that the discharge assessment matches the person, because it doesn't always happen, sadly, where the hospitals often take a quicker line to get people out of hospital, of course, and that can end in simply readmission. But we had someone who was going back to aged care housing, which, if you don't know that setup, it's effectively somebody has an independent flat and they have sort of domiciliary care that goes in to support them to a greater or lesser extent. And this person, because they had a medical episode, they were declared medically optimized for discharge, ready for discharge, but actually they couldn't go home because actually it required a mobile hoist, and the mobile hoist wouldn't fit in their bedroom. So effectively what they needed was the bedroom and the lounge to be swapped over. Wasn't responsibility of the acute hospital, wasn't responsibility of the social worker. It wasn't responsibility of the extra care housing, because they only provide the domiciliary care support. The lady had no family. This person was stuck in hospital, desperate to go home, ready to go home. Actually, no one did it. And I'm very proud, actually, one of my staff, who is over retirement age herself, but basically got a neighbour, and they went in and they changed around the beds and the furniture, etc., and got that person home. But those are some of the kind of fundamental blocks that we have around the systems that we use, where we all work in silos and we simply can't move forward. So it's not a data issue, it's just a kind of responsibility issue. And sometimes we need to we look at it in the round a little bit more and think, how do we get this person home?
Yeah, I agree. But in many cases, if we could actually start using technology to remove those, let's say, not manual coordination, but to remove the effort, so that if everybody involved within the person's care knew that equipment was needed, and then if one person says, well, it won't fit here, then everybody gets to know about it, rather than just that one person having to lumber on themselves. So great point, really valid point.
Hi, could I speak, please? I can't find the raised hand either. Is that okay?
Please.
Thank you. Hi, Paul. I'd like to talk to you as well, please. I'm actually developing a care pathway to better manage long-term conditions in care homes. And the only way that can achieve the best outcomes for the people in the homes is if clinicians are fully integrated into the pathway. And that's where you immediately recognise this need for data orchestration and to have the kind of approach that you've described, so that whoever needs to be looking at information about this person can access it. And with diabetes especially, which is what I've started with, you've got, the GP in primary care, you've got a podiatrist in community care, you've got a dietitian in secondary care. And when it comes to reviewing that person, the information is scattered all over the place. And I've been collaborating with the PRSB, and when they did their research for the diabetes standards, that's what the clinicians were saying, that we haven't got the information we need at our fingertips. It's scattered. So I've been trying to engage at ICS level with clinicians to try and promote this new way of working and getting the data shared efficiently, to achieve these outcomes. And because of their pressures and lack of headroom, etc., and financial constraints, it's proving difficult. So I'd love to chat with you about how we could perhaps,
Well, I think Jade shared the contacts in the chat there. So please, anybody that wants to reach out to us and say, yeah, let's have a demo, let's have a chat, see where the potential is, because this silo agnostic approach allows so much more flexibility.
The other issue is the fact that the DSCRs, which are very good in many respects, and it's good to see providers using them more, they're not SNOMED coded. So, when you're looking at data analysis by commissioners for value-based healthcare and population health management, they haven't got access to the data they require. Things like UTIs in care homes, they could be managed effectively and reduce hospital admissions, but the commissioners can't see which homes have got the most UTIs, if you know what I mean. They can't see where the training needs to be focused. So if we could get this data orchestration sorted and get the data flowing freely through the systems, it would give us so many opportunities to work much better. The other thing is end-of-life care, the EPAC systems, the electronic palliative care coordination system is being used more widely, but not in care homes. But surely that's an obvious place where it should be used, you know, making sure that people have a good experience at the end of their life is essential, I think.
Great point, Sandra, really valid. And I would actively encourage you to look at some of the work that Dr. Mark Wardle is doing.
I will.
Because he's deeply ensconced in the SNOMED codes.
Okay.
So I think it would be really valuable for you to have a look at those presentations. Yeah.
Okay, I'll get in touch. Thank you very much.
Brilliant.
Sandra, sorry, can I just ask which organization you work for, please?
I've got my own company. It's called QUIC, which stands for Quality in Care. And I've had some Innovate UK funding to start looking at developing software for diabetes management in care homes. But that project's come to an end. I'm trying to raise more funding now to go on to the next stage. And I feel that it's essential to tackle this problem of, you know, sharing data across organizations, because there's no way that care homes can get the best outcomes for people with diabetes without the clinical input. Another interesting area, sorry to go on a bit, but the Enhanced Healthcare in Care Homes framework, which is supposed to be improving healthcare in care homes. When somebody's admitted to a care home, within 14 days, the GP practice, the clinical lead there, has to produce a care plan. At the same time, the care home are producing their care plan. So you've immediately got duplication. You've got no single source of truth. And I've asked a care coordinator in a PCN, how do you keep these care plans in sync when for the health related issues? And it can't happen. You know, you've got the weekly ward round for IHSCM happening, and you've got carers in 70% of the homes, they're not even clinically trained, go into these weekly ward rounds. Discussions there are uploaded to a GP system. They're not uploaded to the care home system. You've then got a non-clinical person having to interpret what's happened at that meeting and uploading it into their own system. And it's inherently risky. It needs to be addressed, I believe.
Sandra, just to leap back to the diabetes thing, are you familiar with Partha Kar at all?
Yes, he's very much into CGM, etc., and he's done fantastic work. I've been Professor Alan Sinclair is the champion of diabetes in care homes, and he was the chair of the National Advisory Panel for Care Homes Diabetes, and he's been supporting me what my approach, because the digital framework I've developed is actually to translate the NAPCHD and NICE guidelines into a format that gives a step-by-step approach for people working in care homes.
Yeah, brilliant, excellent.
Helen, would you like to come in?
I was just going to ask Sandra if she would pass her email address to me, and then I figured out I could just type this into the chat.
I'd love to talk to you, Helen. I'm keen to talk to as many people as possible. I'm quite passionate about this, as you probably guessed, and it's quite frustrating not, trying to make progress with it.
I will put my email address into the chat for you.
Thank you very much. I'll be in touch. Thank you.
Oh, one question I had was, how does this approach differ from the shared care record?
The shared care record is it currently held on Spine?
No, I don't mean the summary care record. I mean the shared care record that every ICS has, or is commissioning, but every ICS is meant to have one of these shared care records, which as I understand it is pretty much a repository drawing information from each of these silo sources that you refer to. And I know that some of them, like the one in, there's a well-publicized one in Dorset, that was one of the earliest ones to be operational, that has had some success, apparently drawing information from their acute hospitals, from their GPs and GP systems, and I believe social care, but I'm not sure. I know it's certainly on their
Certainly.
roadmap to draw information from the local social care, care management systems.
Yeah. Okay.
So that I'm just asking because those shared care records are, as far as I can see, similar to your solution in that they are repositories extracting information from various sources across the health and care settings.
Yeah, now that is the key point, extracting. So the concept that we're sort of putting across is, well, and I can say this freely now because I think the decision was made yesterday that they're going ahead with Palantir. So here is one of the brilliant,
one of the best kept secrets. Or worst kept secrets.
Yeah. Well, this is what I'm about to say. It underpins why this approach with the FDP is simply the wrong approach. Yeah. So if we paint the scenario that, yes, data is held in an EPR, people extract that, as you say, at the ICS level to give them a repository. And then when they say, actually, the repository is really great, but it doesn't have this information in it. And they go back to the source systems and they say, oh, well, we don't hold that information. And if you want us to hold that information, you will need to pay us X £100,000 to implement that. And then say, well, let's say if we're dealing with London, there's 34 hospitals in London. That means you will have to pay 34 vendors to enhance their systems so that then they can hold the data that they will then push up to this single repository. Yeah. So it all starts to get really, really expensive and really, really complex. So what if, and if we look at the entire length of the data exchange, anybody in the commercial world, particularly in hospitality or retail, will say, well, why have we got this many steps? Why don't we just take all the information and put it straight in the repository? And then if we want any changes, we're only having to, if we've got these GUIs, these standard user interfaces that everybody uses, if we wanted to, argument's sake, say, well, we want a button to for clinicians in A&E to say this is a COVID person, it would take literally hours to update a user interface to put a button that says this patient's COVID. And the repository would pretty much be able to take care of it. There would be no translation, there'd be no cleaning or cleansing of data. It would just literally happen. Now, if there's business logic in the middle that says, if the patient is COVID and they are going to a care home because the bookings repository is telling us they've got a reservation for a care home, then we put some business logic in there to express caution that there may be a potential problem here, especially if that care home hasn't got adequate provision in place for a COVID patient. So all that comes into play really, really easy. So where it differs from the care record, as you were asking, is that the repository approach isn't dependent upon the structure or the data held at those local level electronic patient record type systems. It doesn't have to be. It could, in the fullness of time, divorce itself from all of those and just say, here's the UI, we've got the business logic, and there's the data store. Does that make sense to you, David?
Sorry, can I just clarify one quick thing before I bring Eddie in? So you're saying, I think I heard you say that it can be a challenge and problematic to extract data from these systems.
Yeah, absolutely.
Okay. And therefore, if you're not extracting data from these systems and putting it into your repository, is that correct?
Yeah, it's not my repository. In the clinical sense, no, it's not my repository. And I think, there's a valid argument to say, well, should NHS maintain and control this repository? And if they do, then you'd get all the CCIOs being the curators of that repository and the maintainers of that repository. And then you'd probably have external suppliers doing the UI, and you may have external suppliers doing the business logic. So that still means that the NHS retain all the data in the repository and use it for bona fide real reasons. But there's no reason that, I mean, it can be a migratory path. If you've got everything held in the local EPR right now, and you can say, well, we're going to present an alternative GUI to the EPR. And therefore, we can start writing our own business logic for our own flows. And then slowly but surely, you could actually wean yourself off an EPR.
Okay. Eddie, please come in.
Yeah, I was just going to elaborate really on the shared care records and some of the challenges. So in my experience, shared care records are actually quite rare because they tend to be for people with quite complex problems where there's been a specific attempt to bring together key information about a person who may require a number of services across health and care. So I think we use the phrase as if it's a thing which happens for everyone, but I think it's actually more like a unicorn, if I'm honest. And part of the reason is not just that NHS manages EPR, but of course local authorities have their own system, whether that be LAS or whatever it might be, but they effectively are inputting data into their own system. If they're a hospital social worker, they'll probably have to put it in twice. And certainly my team who work at the hospital, they put stuff in twice. They put it in, so they're looking at EPR for information. They might put a note to say they're doing a discharge assessment. They then have to log that on the local authority system. So they're doing that work twice, duplicating, and that's not uncommon across our health and care system. And then, by the way, of course, we've got the providers themselves. So if you're discharging to a care home, you're then you've got their systems as well in terms of what they're holding. So it's an extraordinarily complex system to bring together, I think, and fragmented. And of course, for some people whose care may be subject to a contract with the local authority or a contract with the NHS, there's that time scale where effectively that care may change from provider to provider. So every 3 or 5 years or something, they may get a different provider, in which case you've got to move the whole lot and all the permissions across to a completely different system. Maybe a small provider who doesn't have that back office capacity, or it may be a very large provider who does. So I mean, it's an extraordinarily fragmented system, and I think that question about who holds it, it probably has to be the NHS, I think, Paul, to be honest, because they are the one kind of point of no movement, if you like. They'll always be there because they are a statutory body. They are responsible for ensuring that everybody's health record is up to date. So I think we probably should all plug into that, and that's where that's the static point, I think, that we connect to. But yeah, I mean, the way we're moving, it will take decades. I should also say that, of course, local authorities have different systems within them. So if someone, has care needs, but they also live in some kind of housing association type set up, they probably they're on 2 systems for that as well within the local authority, who probably don't.
Can I just pick up on the point you were making there, Eddie, about care homes having tech or not having tech? So one of the approaches we've taken with our platform is, well, if they don't have the tech, give it to them. I mean, because our solution is web-based, we could just literally say, well, here's an interface, we will create you a logon, and all you have to do, or we'll upload your capacity, and the moment you have a person move out of your care home, every trust across the UK will have instant visibility that you now have capacity, not the amount of capacity you have, but that you do actually have capacity. And when I say in real time, it's about 4 milliseconds. So the moment somebody presses a button to say this patient has left, every trust, every local authority across the UK, if it was deployed web-based, would have instant visibility that somebody has capacity.
So listen, that's been a great conversation. I'm just mindful that we're coming up to the last minute of our hour. I really want to thank Paul for an excellent presentation and for stimulating what's turned out to be, a great conversation. It looks like you've made some great contacts here, and I think that shows what some of the value of having this forum. So I want to thank everyone for participating. So again, if anyone wants to get in touch with Paul, his details are in the chat. If for some reason you can't pick that up, I'm sure Jade can put you in touch. But again, can I thank Paul, and can I thank all our participants for joining today for a great session, a great conversation.